Okay, Arvin, good to have you back. Arvin Narula, San Diego, interventional cardiologist. We have another video for Shockwave Medical, and Arvin's going to talk to us about the new system, the C2 Plus.
All right, thanks, Aidan. Yeah, I want to talk to everyone about the C2 Plus. So just kind of comparing the two, the old Shockwave that we had, ranges from 2.5 to 4 millimeters, 12 millimeters in length. It goes over an 014 wire. It's compatible with a 6 French guide and 6 French guide liner, the old one is, right? The working length is 138 centimeters. Crossing profile is the same as the new one, but the key differences between the two are the amount of pulses. So Shockwave C2 Plus actually has more and more pulses. And we'll kind of go through this case that we presented, because I'm noticing that I'm treating not just focal spots of calcium, but longer lesions of calcium, especially with Shockwave, because it's kind of been one of those nice calcium modification strategies. So rather than just focusing on one little troublesome spot, I'm kind of taking this catheter and balloon, moving it all across the lesion. So the big changes, again, same sizes offered, goes through over an 014 wire. It still goes through a 6 French guide and 6 French guide liner, but I guess it is 5 French guide catheter compatible. I've not seen a 5 French guide catheter used, but again, it goes through a 6 French guide liner, no problem. Same length, crossing profile is the same. The biggest difference, again, is the pulses. And also the other thing is that sterile packet comes within the balloon, so that's nice. That's one big change. So you don't have that, and it's not sold separately.
Yeah, no, that's helpful. And I think occasionally, how often do you use a 5 French guide? Almost never, but rarely you'll get that kind of little lady with a tiny radial artery, and yeah, it could potentially be helpful.
Right. So here's our case. Here's my referral. I have an 84-year-old gentleman. He likes to garden. He's on 2 anti-anginals, but every time he goes to the garden, he has really bad chest discomfort. And his GFR is under 30. So typically what we do for these cases is we kind of use a little bit of a limited contrast protocol. So if we can stage it, we'll stage things if patients are not in acute coronary syndrome or not having urgent issues. And this guy had kind of stable coronary artery disease. So one of the things we like to do is the left system we shot, there was no major coronary disease there. I like to use this medallion syringe. It kind of just is a little less. It kind of gives you a little more feedback to use 2 or 3 mLs for your injections. I kind of like that. And I remember watching Ziad's lectures and talks on this on TCT and stuff like that. But he talks about engaging the coronary and then injecting saline rather than contrast for puffs, because you'll see these T-wave changes. So that's kind of helpful too. And then to get a good picture, I like to kind of have a delayed injection where you delay, see the calcium, and then kind of give a little injection and a puff to kind of see where the coronary artery disease is.
Yeah, I think that's great. And I totally agree. I think, a lot of times people will just sit on the gas and keep giving contrast. And really, if you do a small amount, we learned this in our fellowship training, just a couple, like on the right, like 1 or 2 cc's, full contrast, but just give it, hard, and you can get a great visualization of the vessel. Yeah, I think where you can burn extra contrast is when they just stay on it and, for no good reason. So,
Yeah, you end up using like 10 mLs if you just use the standard syringe, I feel.
Yeah, at least that limits them, like your tech from doing too much.
Yeah.
So, cool.
All right.
Sorry here. All right. So this is our case again. We brought the patient back. We put up a guide catheter. This is on a separate day. Here we have a 2.5 just compliant balloon that we use to kind of help just pre-dilate the lesion, hopefully get our imaging catheter across. We were able to get our imaging catheter across, but it didn't go much further than this balloon. So, we knew from our previous angiogram that we just needed to treat that proximal segment for this patient. We got IVUS, and IVUS showed that there was nodular calcium, but also deep calcium as well. And it showed that the vessel size was actually pretty large, about at least 4 millimeters, if not more, especially at the ostium. So the image on the right then shows our IVL balloon now. We have our 3.5 IVL balloon here. You can see it's kind of one area of under expansion, but you're noticing again, this is the regular C2. But I was noticing when I'm using these balloons, I'm using all the pulses now because I'm just treating longer and longer segments. What I've kind of started learning is shoot, where my stent is underexpanded is where I didn't shockwave, right? And I
Right.
usually like to use the emitters to really focus my energy on the calcium. So I kind of am pulsing, then moving it back a millimeter, pulsing, moving it back a millimeter. So the C2 Plus is going to be nice because we're going to be able to treat larger zones without fear of, needing to use multiple balloons or having issues with not treating the appropriate segment with as much as we needed.
That's great. Did you have trouble getting that down? You said the
A
IVUS.
little bit. I didn't need a guide liner or Guidezilla. I didn't need anything, but I was able to get it down actually, which is nice.
Nice.
Which eventually was. But again, I would have probably ended up switching for a wiggle or something like that to kind of help me do that. But after the shockwave, here's the non-compliant balloon we used here. So the NC balloon shows good expansion again. This was a 3.5 NC. We showed we were able to kind of get good expansion there. And then here's our stent. Again, we wanted to kind of limit the amount of contrast we use. So we kind of marked the aorta with a guide wire. And I feel like I ended up landing a few struts more into the ostium than I probably would have liked. But I think I made one mistake here. I probably should have done IVUS to mark the ostium as well as use a wire. That's kind of helpful because there's so much calcium here that you have such good visualization of this that you could probably really, really be pretty accurate with your stents, especially if you have all these markers in place.
Yeah.
All right, so here's our final result of the our last shot of the RCA. Again, I think maybe a few struts in the ostium, but if you look at the IVUS on the right, you see multiple areas of fracture throughout the vessel. And again, I'm glad that we used it because again, with a guy whose creatinine is not great, GFR is under 30. I mean, using Rhoda and all this stuff, his heart rate's kind of already in the 40s. It's just one of those things that it just becomes way more dramatic than it has to be. And you always worry about kidney function and what does the vessel look like after Rhoda and things like that. But I feel like IVL has kind of become a nice, safe therapy, especially if you can deliver it to really treat that. So I think C2 Plus is going to be a big game changer in terms of treating longer lesions. That'll be the nice part of that.
Yeah, no, I agree. I kind of feel more comfortable not taking a bunch of, because if you're doing Rhoda, you definitely want to take more pictures, make sure you haven't dissected or distal emboli, shutting the vessel down. And it seems to be pretty predictable and, don't really worry about that too much with IVL.
Mm-hmm. Yeah, and then again, I think here, if I had osteoflash, I probably would have used it, but we don't have that yet. We're working on getting it in. Do you have that, Aidan?
No, I haven't. I've heard, kind of, I don't know. I think a couple people have used it, but we don't have it in our hospital.
Yeah.
You heard good things?
Yeah, it's nice. You can just comfortably leave the stent out in the ostium. You're not going to miss it, and then you just kind of post dilate it up.
Yeah. No, I think it's. But if you could have taken 50 pictures to try to line your stent up. And
exactly, and that's the issue with this case where, you always get worried, especially when our patients are getting older, and again the GFR, you want to kind of minimize that. But again, IVUS, I probably should have done IVUS to identify the ostium on fluoro and IVUS. That probably could help too.
Sure.
Mm-hmm.
Cool. Is that your last? Did you have a final IVUS on this one, or?
And then here's the final IVUS. And again, the last discussion, I guess, is I used a 4020 NC to post dilate the stent. Mm-hmm. And again, kind of the distal edge of the stent, because again, this is just with the stent itself. I got an MSA of around 8. My partner and I were discussing, would you touch that up? Would you go after it? Diminishing returns, the law of diminishing returns. What's your goal here? Again, I think what our goal was to minimize contrast, do a procedure safely. He told me he would have gone up with a 4.5 proximally and a 4.0 distally. Again, I don't know. Everyone kind of practices differently. This is it within the same practice. We have different practice variations. Aidan, what would you have done here with that distal?
Yeah, I think that's a pretty good. Look, your proximal, MLA is 10. You got it to 8. Mm-hmm. I think you went pretty high pressure on an NC balloon, right? How high you go?
18, just a nominal. I use a Xion blue wire, so when I go more than that, it kind of gets sticky on the balloon.
Huh. Yeah, no, I would go just a little bit higher, but then I think it's like, look, you've gone up high on an NC. I think at some point you start to, there's a risk reward here, and I think
funny, Aidan. Like I feel like in the pre-shockwave era, you would have taken this result any day. An MSA 8 with a super calcified vessel.
Yeah, and you wonder maybe a couple more pulses down there and could have helped. But look, I think a focal area like that, pretty reasonable expansion. I don't think it would have any clinical changes. So
times have changed.
Yeah, nice. So C2 plus should be helpful.
And it comes with the bag.
And it comes with the bag. Yeah, I hate that. We'd have to put it on. I'll be just a little bit quicker. But you know, sometimes those things can actually slow you down with a new tech, and that's awesome. What else do you want to see out of this balloon, Arvin?
Oh, this is what the fans want. I think we are seeing more and more longer lesions and longer zones of calcium. So my dream is that there's more emitters on these balloons, the longer balloons, like a 20 millimeter balloon with more emitters would be so nice, kind of like the peripheral. That way we're not moving it back like half a millimeter. And the other thing is, sometimes when we have issues, when there's a really tight spot, it'll like slingshot past that spot you really, really want to treat. And that's tricky sometimes. So and then if you try to push it forward, you'll never get it through again. So more emitters would be the dream for a longer treatment zone. That's what the fans are calling for.
All right. Well, I don't know if there's technical issues with that, but yeah, I mean, it's a good thought. 12 is, these long lesions, 12 is a little bit short. But at any rate, great result. Nice pretend house behind you there, Arvin. Looks great.
Thank you. I'm going to learn the piano soon. So.
Okay. All right, guys. Well, great case, and we'll be looking forward to the C2 Plus coming out.
Awesome. Thank you, guys.
All right. Signing off from Murmur. Thanks, Arvin.